He is the practice director and licensed financial planner of UOB Kay Hian Wealth Advisor Sendrian Berhad. At the same time, he is also the committee member of Persatuan Community Emas Suvarna Mitra, which provides the assistance and care to an elderly group. Currently, he is doing a postgraduate research on health economics with UPM. And you know, he was even the first and only Malaysian who being awarded as the winner of Plan Plus Global Financial Planning Award Asia region in 2014 for the high quality financial planning advice. So everyone, ladies and gentlemen, today he is going to share with us the sustainability of health financing system in current demographic transition towards the aging society. So, ladies and gentlemen, let us welcome Mr. Gavin Teo.
Thank you, MC. Thank you, organizer, and thank you, co-organizer. Give me a few seconds to upload my slide.
Sure, go ahead.
All right. So today the keyword is sustainability. Many of us talking about this topic. In fact, this is a very big topic. Today, people talking economics, healthcare, politics, sustainability. But tonight, my topic is about health financing sustainability in times that the country moving to aging society. So, Dr. Siti has highlighted most of my point, as you can see my slide, but I would like to bring you to the diagram that you can see on your side. You can see in year 2050, population with age 65 exceeded a population below 14. That is the time we call it age society. Yeah. Unfortunately, Malaysia have very short lifetime to prepare for this population transition, or I call it demographic transition. We only have 23 years from from last year, 2027%, it will jump to 14% in 2043. If you compare to a more developed country, their experience, especially like in UK, they took 45 years, and US took about 69, while in France took about 115 years, according to the World Bank record. So we have a pretty short period, yeah, to be prepared for ourselves. So, as what Dr. Siti say, age society or aging society is actually is affected because of the life expectancy change and the fertility decline rate. So if you look at the life expectancy in year 1960, average Malaysian can live up to 60 years old. But unfortunately, I will say that we can live longer up to the 76 years old in 2008. Today, I think we are about 76.4 on average. Yeah. So if you look at the fertility rate per woman in those time 1960 is 6.5 children. Today is only 2 children. So I believe today maybe 1.8, 1.9. That should be a latest data. So these two trends is actually affecting the demographic changes and bring country to the aging society or age society we call it now. So talking about health financing system, first thing we need to know about health spending. If you look at the diagram beside there, is the J-shaped curve, and this is what happened in Japan. The similar thing will be happen to the Malaysia. Yeah. So you look at the when children just born, the health spending or health expenditure is a bit high, and it gradually go down. But toward old age, there is a steepening, a trend that gradually go out and very very fast toward old age. Yeah. So what does it mean? It means that there is a concentration of lifetime health care costs at toward the end of the life, or we call it proximity to the death. So coming back, the third point I need to highlight here is that from the United Nations research, 88% of people spend in the good have good 88% of our life expectancy actually in the good health. In Malaysia, life expectancy today like 76 years old. It means about we only have 60 years in the good health. Yeah, the remaining 12% actually in the bad health. So that is what the statistic has proved to us. All right. So talking about Malaysia's health system, I would like to highlight this research done by Howard University, engaged by Minister of Health a couple of years ago. He made a statement very clear that Malaysian health system in asymmetric transition. It sounds not good because that a rapid transition have not matched with the corresponding transition in the health system. Yeah, so that is a problem that we are going to face for current and the future needs. Yeah, so the main factor is actually come from a demographic factor. As I said just now, that due to lifetime expectancy, increment in lifetime expectancy, and decrease of fertility rates. So that caused a trade-off between human capital spending and fertility. People will spend more for children education and health now. So that is actually improve our health so much, and health spending is increased tremendously. The second thing is the due to prevalence of a non-communicable disease, NCDs. We call epidemiological transition. Basically, it's talking about like stroke, cancer, and heart attack, and so forth. So the data show that things are getting worse. From the measurement done, they called DALI in 1990 is about 60%. Today is 70. Not today, sorry. In 2013, the rate is 72%. So it's increased very, very high. And I'm sure today will be higher. People tend to be less do physical exercise, eat the wrong food, and things like that. That will cause increase of this NCD. Yeah. All right. The health financing system. If you look at the data of health spending that we have gathered from Malaysia health account, that you can see. One side, the blue side is a public health expenditure funded by government, and the orange is the private health expenditure, which is funded from ourselves. It could be from insurance, it could be out of pocket, it could be from your EPF and pension scheme and so and so forth. Yeah, for same thing to the public. Yeah. So, but the issue here is that since 1980, government adopts privatization. So we actually go it very, very aggressive, and also we face the financial austerity. You can see that especially in year 2008, which is a global financial crisis age, the government have a limited budget. It has dropped significantly to 5.48%, and of course it increased back in the later year, but we remain steady about 7% throughout these many years. As compared to international benchmark, it could be, it says that 11.5%. So we are really below what a setting set by an international level. So I think some of you may come across in the newspaper or be bombarded by certain media out there that our medical inflations are relatively very high. And this is actually related to private healthcare. Is that true? Yes, it could be, because this research was survey done by two remarkable companies. One is Wheeler Tower Watson, another one by this broker company, Mercer Mars. And you can see that Malaysia has 13.4% per annum. Yeah, and on average, I will say that around 13% for both companies. And the global rate is about 9.7. So we are amongst the countries have the highest inflation rates. On my calculations, our inflation increased so much, escalated so much after 2008. On my geometric means calculation, I saw about 7.2%. Before 2008 is about 3.2%. So that is a tremendously growth after global financial crisis, probably because due to financial austerity and the government are pushing more for private healthcare. Yeah, or maybe we expect more private healthcare services as well. So on the nominal total healthcare expenditure per capita, growth at the 7.7%, higher than our GDP per capita. Can you imagine? We spend more than our GDP per capita. I think this is very alarming, yeah, to us. Okay, I take you to more scientific graph here. You can see that the issue that I would like to highlight is called financial risk protection. And this is very extremely important, especially to United Nations, because the incident allows catastrophic health spending through out of pocket. That means we come up with our own saving, our own investment and saving to pay for medical fees, and that will actually disrupt our long-term health care. Yeah. So, and if exceeded more than 40% household income, that is the disaster. Yeah. So, what is the alternative? The alternative is actually called pool financing. It could become from insurance, private voluntary health insurance, or sometimes we call medical insurance. It could come from your EPF, so and so forth. Yeah. So let's look at this out-of-pocket issue. If we compare to our peer country like quite similar to Malaysia, like Brazil, Mexico, we will have a medium to upper income, or even Thailand, our neighboring country, we are not good at all. Our outpatient spending, out-of-pocket spending share of current health expenditure is growing since global financial crisis, as what I highlighted just now. While other country is going down, this is not good. If you look at the absolute value, it's completely no good. Yeah, and if you look at this chart, it's a bit more complicated. Let me simplify it. If you look at the x-axis, the bottom there is say a poor financing per capita. That means it's through insurance mechanism, EPF, and sorry. Well, here it's out pocket. It's come from our own money. And Malaysia is just past the line, the 45-degree line, which is caught in between alien number 3 and alien number 2. For your information, alien number 1 is the perfect. That means they have the right, they do a right thing, a right pool financing mechanism in the country. We have a good example, Thailand. Yeah. Well, country here is not too bad. Well, country in the third area is pretty bad. Yeah, it's not doing anything good. Of course, over this side is completely out of what we can see, yeah, or what we want to follow. So Malaysia is just past the line, which is actually, I would say, is not really good anyway. So it's something we have to do about it for health financing system. So my advice is that a government should intervene in regulating private healthcare. I think in this year, many of us, especially you buy any private health insurance, I'm sure you experience the increase of premium. Yeah, but the insurance company is inevitable to increase the rate because private healthcare expenses or costs are increased tremendously, especially during this COVID-19 time. Yeah, so this is something government have to do. Yeah, rather than leave it to the free market. Second, it would be that introducing the private voluntary health insurance, like just now medical insurance, but unfortunately, this method could be able to cater N40 or T20 people. For B40, they may find hard to acquire any insurance for that. So this insurance, it would be good that extend to other areas are not currently covered, where you can see many people still use out-of-pocket method to pay for it. Example, the primary care, dental care, health maintenance, and so forth. So this is something that some financial development have to be done here in this area. Yeah. So the third things that I would like to suggest is that, and this is a bigger issue, yeah. So the government should be brave enough to introduce a mandatory universal health financing. It would be the good because that government own the insurance company, government control the price, and this model have been done by several countries through these three type of model. One will be a national health insurance, like in Korea, like in Taiwan, which have done it very, very well. Yeah. So they are partly funded by government, depend on your occupation, and partly you pay for premium for that. Yeah. A Bismarck model is some sort is related to a social insurance, which was formed in Germany and today implemented in Japan. Yeah, you're talking the Asian country, I can see Japan is using that. And I think yesterday's speaker I mentioned about this long-term care insurance. Yeah, this is part of the Bismarck model as well, where the model is look like EPF, partly employer contribute, partly contribute by employee. All government subsidize for certainty, especially for sole proprietor or freelancers. So that is model that actually go to the pool fund managed by insurance, and government itself control the pricing of the private and public healthcare. The third model is the model used or adopted by UK. So where it use a tax system where majority of healthcare services are delivered by a government. So the tax is actually factored in the cost of medical that it be able to sustain the health system. So basically, the sustainability healthcare financing, I think, is very, very crucial now, especially with this COVID-19 pandemics. We are really, our health financing system, and even our health system is really tested now. So I would love to see that government do something for that. Otherwise, I think we will face a long-term problem. Yeah, we will face that a more increment of the premium, and also we face a higher private healthcare expenditure. Well, the government slowly or already gradually already push for it for the private healthcare. So this is something that all of us have to sit down. People, policy makers really have to take it seriously. In the earlier time, during earlier government, Dr. Zulkifli at one particular media session, I remember it came out newspaper, said that government tried to introduce social insurance, a Bismarck model. I was so happy during the time, but unfortunately, our government is not stable. Things have changed. So, but nevertheless, we have seen something in Selangor. By the way, Selangor have formed something like this. It's called Selfcare. Yeah, where the government Singapore, Selangor government own an insurance in Labuan, where this insurance is actually paid for medical expenses, primary public health care, yeah, and some clinical care as well. So this is something I think government should do, and perhaps we have to extend, go wider scope to the maybe hospitalization rather than just primary care. So that's it, my talk. So I love to see some things will happen in Malaysia, especially on the healthcare financing system. Thank you very much.